Okay. So I think we'll get started here in a second. I see there's people in. I don't want to hold anybody up, so we'll give it just another minute here. Can you guys all hear me? If you can hear me, can you put something in the chat saying a thumbs up if you can hear me? If you can hear Sweet. Okay. So I'm just gonna get started here because we only got like 30 minutes. So I'm Betsey Neddermeyer. For those of you who have never met me, I am a board certified physician assistant. I have been doing functional medicine now. I trained in functional medicine about 4 years ago and been actively practicing it for the last 2 years. My background is traditional though, so 9 years of traditional primary care. So I've got a little bit of both backgrounds. Um, what we're going to talk about today is purely functional medicine. I marry the two, but that's basically what it boils down to these days, as far as true body care. I have a presentation that I'm gonna go through, 'cause I thought it would be easier because I wanna touch on hormones, and I wanna touch on PRP, and, I will have, obviously, if I'm talking fast and you have questions for me, I want you to put those in the chat, and I'll try to get to them as I'm going through, but we can also address everything at the end too. So let me pull this onto the screen. Okay. I think hopefully you guys can see that pretty good. So the basis of this is that your labs are normal, but you feel awful. And so really what I want to dive in today is two different case studies. One's going to be a female, one's going to be a male. These are real labs, but not necessarily real people because I want to keep everything confidential. And so this may or may not fit you or might be have some similarities. So, um, okay, so I want to make sure I have to like toggle back and forth between the chat and here. I hope you guys can kind of see the, there we go. Okay, it should get clear. Okay, so this is a very typical patient I would see. So this is a 47-year-old female. Her symptoms would include fatigue. She has some stubborn weight gain, low libido, and insomnia. And she has got her labs drawn, these exact labs, through her primary care's office, and they have said, "Well, they look pretty normal to me. Um, I don't know. I don't have any suggestions for her. It's just getting older." And so then she came to me. We did the exact same labs, and these are them. And we had a different take. So I'm gonna go through what I saw. So the first thing you'll see is her general chemistry panel. And so on her general chemistry panel, that's just looking at her blood sugar the day we drew her blood. Those next three, your BUN creatinine, or her kidney function. The next, her electrolytes, her sodium, potassium chloride, CO2. We're just looking at basically are her electrolytes in balance. Then you're looking at her nutritional proteins, her calcium, her total protein, her albumin. From there, you're going into liver proteins, which is your alk phos, your ALT, AST, and then the last one on there is kidney function value. So all in all, we're looking at all those different things, and there's a reason why we're looking at those because hormones are transported proteins to be good, which in this case, those are ideal. We also want her to be filtering things through her kidney as well, things like that. So very good metabolic health. And then you go into her, I gotta move this so I can see it. You go into her cholesterol panel, and, in this particular patient, she was placed on a statin because of the current labs that you see, and so they saw her LDL was a little high, and so they said, "You know what? You need to go on a statin medication." But really, when you break this down, her total cholesterol was only 184, and that's comprised of her triglycerides, her HDL, and her LDL, and her HDL is her good cholesterol. So you calculate someone's risk of developing a cardiovascular event by taking her total and dividing it by her HDL, and that's how you get 2.9. And as long as you're a female and your risk ratio is less than 3.5, you're sitting in a really good position. So you're actually able to discontinue a medication right out of the gate. But with that being said, we talk about hormones in this particular case because estrogen increases HDL, and HDL is your good cholesterol. It's cardioprotective. It's actually what takes LDL and your triglycerides, grabs onto them in the bloodstream and takes them out of the bloodstream and prevents them from embedding into the walls of the arteries and getting plaque buildup and increased risk of cardiovascular disease. And so estrogen is a key component here. So not only can we discontinue a statin, but potentially by increasing our hormones, we can already reduce her risk even further. And so that's one of the key components that we want to look at because we want to know where her baseline HDL is and just her lipid profile in general. And so then the next section is her thyroid. So her thyroid, this is usually more than you're probably used to if you go to just a traditional office. So you'll probably recognize TSH in that thyroid panel there, and TSH is your brain. And your brain is responsible for just assessing where the hormone level is for thyroid. And so you could think of it like the lower that number, the more content it is with where your thyroid levels are at. So it is happy of like the level of your T3, your T4, all that it is content. The higher your TSH, the less content it is. So the higher the number, you can assume that your actual level of hormone is not good enough. It's not high enough. And so when someone comes in and they have a TSH of 1, we can assume that their brain thinks that that level is ideal. So then you go to the actual levels of hormones. So that's the next step, right? We don't want to trust our brains. Our brains aren't always right. So then you go to the actual levels. So your thyroid in general makes 4 hormones, right? Your T1, your T2, your T3, and your T4. So in this particular case, when you think about, okay, my thyroid's making all these hormones, which ones do I care about? Okay, well, 99% of what it makes is T4, but T4 is not the active hormone, T3 is. And so we're relying on our body, our gut, and our brain to convert T4 into T3. So when we're looking at hormones, we could run a T1 and a T2 and a T3 and a T4, but ideally, your 99% of what you're making is T4, and so we wanna know what that number is, but we also care mostly about T3 because that's what's actively working on all the symptoms we care about. So when we talk about thyroid, we're talking about hot and cold intolerances, we're talking about hair thinning, brittle nails, dry skin, we're talking about fatigue, we're talking about weight gain, all these different components are your thyroid, but T3 is the one responsible for fixing them. So if your T3 isn't great, it may not be fixing those things. So in this particular case, we can say, okay, her T3 is 3.2, and her T4 is 1.22. So we know that she's converting because her T4 is less than her T3. So it's being converted, and it'll always be less than T3, and that's on purpose. And we can see that her T3 is at 3.2, and that's technically normal. So on a functional side of things, we're looking at what's optimal. So when we look at studies on a functional landscape, we're looking, okay, when are all those things good? When are the fatigue improved and the hair thinning and the brittle nails and the weight loss? When are all those things fixed? What level of T3 fixes those on average? And that's a T3 above 4.5. So in this lab, that would be outside the normal range. And so this is kind of where those lab values come into play, where We don't really care what the reference range is. We need training in the functional side to determine based off studies what's safe and what's optimal for most women, and men for that matter. So in this case, this is an opportunity for her, to potentially increase improve those symptoms by supplementing her thyroid, adding some nutritional components to her diet, adding some thyroid hormone, or if she's already on hormone, increasing that hormone, changing it from a synthetic to maybe a natural. So there's a lot of opportunities within that value that maybe her primary already said was normal. Okay. The next section is your progesterone. So progesterone is responsible for your mood, anxiety, depression. It's also helpful for sleep. And so when we talk about progesterone in a female, we in order to not be estrogen dominant, we need a good progesterone level to even that out, and that's a progesterone around 10. Some women like that to be in the 30s, some even in the 50s, some just around 5 or 7. We have to find your sweet spot, but on average, that's around 10. And so in this particular case, this is a very, very realistic number for progesterone. That's pretty common with somebody who hasn't been on hormone. So she has an opportunity to get on some progesterone at night and make that certainly more optimized. She is still making estrogen. So she is still having a cycle. She is still having a monthly period. And so her estrogen is beautiful. We never want to suppress estrogen as long as estrogen, you want to keep it. Estrogen is what's responsible for reducing that inflammation in the brain, reducing your risk of osteoporosis, reducing your risk of Alzheimer's disease, um, reducing your cardiovascular risk. So we want estrogen. And as soon as you start losing estrogen, we want to give it back. So in this case, she doesn't necessarily qualify for estrogen. However, if she told me, Betsy, you get really bad migraines, and I'm getting some hot flashes and night sweats, and I have some really bad vaginal dryness and things like that. Although this number is normal, we may consider some sort of therapy for her of estrogen to improve those things. So that's just another example. The next one is DHEA. DHEA is a hormone for telling the adrenal glands to do their as far as increasing estrogen and testosterone. And so DHEA for a female, usually around 100 to 200 is ideal. This is a great DHEA. This is actually common value for most women. Most women are below 100. The nice thing about DHEA is it comes in a supplement form. So DHEA, if you think about like hormones in production for females, we think, okay, our ovaries make all the estrogen and testosterone. If we don't have ovaries, we don't have any of those. Well, that's not true. So our adrenal glands can help with estrogen and testosterone production, and our adrenals can also, our adipose tissue can also help with estrogen production. That's why we have a hard time losing weight after we are through menopause. So, which we can address as well. So basically your DHEA is going to help optimize those levels without actually being on hormone or in addition to hormone supplementation to optimize those values. So that is an opportunity to get up just a smidge, nothing crazy. Her total testosterone is 39. So don't look at reference ranges here either. So the interesting thing is testosterone is not currently approved by the FDA females, and so we don't even know who came up with that reference range or what it even means. But we know what testosterone does. So testosterone is endurance, recovery, motivation, energy, mood, sleep, libido, weight loss, brain fog, also Alzheimer's reduction, all those different things. Um, for a female, so if we're trying to decide, okay, what level of testosterone checks all those boxes and is safe, that is a range on average of a total testosterone between 150 and 250. That's on average. So we don't chase that number, but that gives us a good base of where to start. She has a significant opportunity to get that testosterone up, right? 39. I mean, she's barely moving along here. The next one is her free testosterone. So testosterone total, we don't chase, and we don't chase it on purpose because a lot of that's inactive testosterone. On here, I don't have her SHGB. Think of that as, so that's your sex hormone binding globulin. That's a protein that, when bound to testosterone, doesn't want to let go, so it makes it inactive. So all of us have a percentage that our body naturally wants to bind, and so it will make it inactive. So, the the total testosterone or the free testosterone here is gonna be low because of what's bound, but ideally, we want that close to 5, and that's also an average, so everybody's different, but it gives us something to work off. She's at 0.5. I'm talking 5.0 average. Some people like to be at 9, some like to be at 3. Everybody has a different sweet spot. And then the last thing on here is cortisol. And her cortisol is actually really good. It's 6.2. And so I usually say less than 10 is ideal. Now this is just a cortisol like snapshot in time. And so basically when you talk about ideally, if we really wanted to hone in our cortisol, we would do like a 24-hour cortisol test, which we certainly could do. Um, but I don't with her cortisol just right now being pretty low, maybe not is a game changer. Now, if we got her hormones optimized and she was still having some issues with fatigue and irritability and poor sleep, I'd be like, "Yeah, let's check out cortisol for sure." But as of right now, I wouldn't say that's like our main focus. So, as you can see, like her labs look completely normal. We just nailed down several opportunities where she is not optimized and she would feel so much better and a lot of her symptoms would get better. So for this particular patient, I optimized her hormones. She got a little bit of everything, to be completely honest with you. For her, libido was an issue, so we did, an O shot. For those of you who aren't sure what an O shot is, I'll get to it at the end of this. So, the other half of this is about PRP and stem cells. So we basically drew her blood, spun it down, injected that into the clitoral muscles and everything, and improved her sensation, and, vascularity. So during intercourse, you know, she feels better. She definitely so her sleep improved, her energy improved, her mood improved, her mobility improved, and she was able to lose a significant amount of weight. I think her weight loss to date is, over 80 pounds, so pretty cool stuff. Do you guys have any questions on her before I go to this gentleman, this next case study? I only have 2, just a guy and a girl. I'm gonna start going, and then I'll check the chat, and I'll make sure if you guys do have questions, we can come back to it. So, let me next slide here. Okay, so the gentleman, his name is Matt. He's 45 years old. He came to me with brain fog, low motivation, loss of muscle, and some joint pain. And so, just look at the chat really quick. Okay. Um, and so, same thing for him. So, in this particular case, let's see what I've copied on here. So his metabolic panel was great. I don't have that on here. There was like just same as the female. There was no problems with kidney, liver, electrolytes, blood sugars, things like that. His cholesterol panel again was he's got 2 things in the red. So his total was 203. His triglycerides were 106. His HDL was 66, and his LDL was 118. But his risk ratio, taking his 203, dividing that by his HDL good cholesterol, brings that down to 3.1. Guys are a little bit different. Their risk ratio can be just a little bit higher than ours, but I still just do rule of thumb, try to get that less than 3.5. So he and his is 3.1, so that's really great. And then also just to give like an opportunity right out of the gate, if he were to be treated on testosterone, testosterone is naturally converted, or we call it aromatized, into estrogen, just a small percentage of that, and everybody's different as far as how much they convert, but whatever aromatizes into estrogen will increase his HDL and therefore reduce his cardiovascular risk, reduce his risk of Alzheimer's disease, all those different things. So, um, although he has a good HDL right now, he has even more opportunity to make that better. So then the next section on here is his blood count. I put this on here specifically because there's nothing wrong with it. As you can see, his white count is 4.9, his red count is 5.34, and then if you go all the way to the bottom, the second to the bottom is his platelet count, which is 2.85. Those 3 categories are completely normal. Everything in between that is giving us kind of the nitty-gritty of the cells. It helps us to determine if someone has an anemia, if it's a large anemia or a small anemia, meaning microcytic or macrocytic, one's like an iron deficiency, one's a B12 deficiency. There's a lot of different reasons. It could tell us, did he have a recent surgery? Was he recently sick? So it gives us a lot of information, but the big takeaway, if someone is going to go on testosterone therapy, is to look at your hematocrit. Your hematocrit, think of it like your blood viscosity, how thick your blood is. And so his hematocrit is 50.3. And so specifically, he has a great hematocrit, completely normal. So we know that this is his baseline. If his hematocrit climbs, we will watch it. There is no studies and no actual cases to date that say an elevated hematocrit causes blood clots. However, it is something we just pay attention to. So if the hematocrit rises to a specific level, we'll sometimes do what we call a therapeutic phlebotomy, which is basically blood donation, or you can donate your blood, just basically to reduce some of that viscosity. But to this day, and even not even testosterone patients, anybody who has an elevated hematocrit, and that's it, just an elevated hematocrit, there's been no cases or no studies to this date that actually correlate that to an increased risk of blood clots. But you will hear your primary care provider over and over mention stuff about, well, if you go on testosterone, you'll have a blood clot. It increases your risk of blood clots, and it does not. There's not one study out there. If you can find one, I challenge you to look and present it to me, but I bet you can't. So very interesting fact, but that's why I do it. We just want to watch that for peace of mind. The next section is thyroid. So same breakdown as a woman, right? So his TSH is 2.7, so we can assume his brain is content with where his labs are, where his actual hormone levels are. In his actual hormones, his T3 is 2.9 and his T4 is 1.43. So we know that there's conversion happening, that T4 is less than that T3. However, his T3 is not optimal, right? So same thing goes for men. Ideally, in order to control fatigue and weight gain and brain fog and thin hair and brittle nails and dry skin and all those different things, is we want a T3 above 4.5. So he has an opportunity. And then I didn't mention it on the gal before. Both of these patients are completely normal as far as their TPO antibodies, but this last value on here is called your thyroid peroxidase antibodies, and it has a little caret, meaning it's less than 28, meaning it didn't pick up any antibodies. The lab didn't analyze it. Basically, if that number was higher than 28, this is saying less than 60 is normal, but in my eyes, if you have any antibodies detected for your thyroid, that is a very high likelihood you have Hashimoto's. Hashimoto's is an autoimmune disease. Autoimmune means your body is attacking yourself. So, like rheumatoid arthritis is an autoimmune disease where your joints are being attacked. Um, Psoriasis is an autoimmune disease where your body attacks your skin. Everybody, you have all these different autoimmune diseases. This would be an autoimmune disease where your body attacks your thyroid. So in this particular case, none were detected, but let's hypothetically say you had 31 antibodies detected. That's enough for me. You shouldn't have any. Why should you have anything in your body attacking itself? Why should any of that be normal? And so a lot of times when we go through this, we're looking at a lot of newly diagnosed Hashimoto's because of we're just running, whereas they don't usually, because you can have Hashimoto's and have completely normal thyroid levels. So that's just something I want to just brush on real quick. Um, A1C I want to touch on too. So in this particular case, his A1C is 5.5. Some of you may have gotten an A1C before, and that's basically to determine whether or not you have diabetes, right? So if we're like, oh man, you have family history, or you're overweight, or your blood sugar was a little high when we drew your blood, we're going to run an A1C. And we're usually just doing that to diagnose whether or not you have diabetes. So in my mind, yes, I care if you have diabetes, and I want to fix that. I want to reverse that, and we will. But if you have an A1C above 5.0 and you're trying to lose weight, that's the problem. So an A1C is telling you what your insulin sensitivity is over a 3-month period of time. So you can't be like, well, I wasn't fasting and that's why it's high. It doesn't work like that. It's a 3-month average. So even if you weren't fasting or you were fasting, that number is probably going to be that number. But basically, if your insulin sensitivity isn't very sensitive, you're gonna have high insulin. And if you have high insulin, which I didn't put an insulin on here, but we can run just an actual insulin level on people. If your insulin is high, it's gonna increase your cortisol, it's gonna lower your estrogen, it's gonna increase your inflammation. Insulin is terrible. So we if someone's trying to lose weight and their A1C is above 5.0, I know that they're having a hard time losing weight. They're not a diabetic, but they're struggling. So we talk about certain lifestyle changes, certain supplement options, certain pharmaceuticals, maybe GLP-1s. We have options to get that under control, reduce inflammation, lower insulin numbers, increase insulin sensitivity, which all in all encompasses better hormones. So that's a big player. That's why that one's on there. And then a male's hormone panel looks a little bit different than a female's. But basically, you've got LH, which is the testes. So the brain's telling the testes to make more testosterone or not. And then you've got estrogen levels because you're converting some testosterone into estrogen. But the big takeaway for this gentleman is his total testosterone is 370, and that is technically considered normal. Most men have symptoms less than 800. Ideally, we want that between 1100 and 1200 to reduce the risk of Alzheimer's disease and cardiovascular risk. And so, big problem there. His primary care provider would say that's a complete level for a 45-year-old, and that is a huge disservice to this gentleman. So this particular gentleman, we put him on hormones. We did some PRP injections. Um, feels amazing. He's gained muscle, he's lost weight, better brain function, better confidence, whole person. So, let me check the chat real quick. Okay, nobody has any questions so far. I'm like, I love this stuff, so I just get a little carried away here. So just like briefly, okay, the difference between functional and conventional, right? Normal ranges versus optimal ranges, treating root causes versus um, and then symptoms. So I'm going to look at your labs, obviously, but at the end of the day, I care about how you feel. And if you tell me you don't feel good, I don't care if there's no red on your sheet of paper as far as your labs go. We're going to figure it out and we're going to fix it. So that's kind of the big takeaway here. Next slide. This is just a web I created. I just kind of wanted everyone to know like how it's all intertwined. So like adrenals, like I said, they sit on top of each kidney. They're your stress response. So if you have chronic stress, you're gonna have high cortisol. If you have high cortisol, you're gonna have lower insulin. You're gonna have high inflammation. It's gonna disrupt your thyroid. If your thyroid is disrupted, that can cause Hashimoto's. So in order to reverse Hashimoto's or get your thyroid under control, we got to fix your adrenal glands and your stress. As far as your thyroid goes, that's the next one, right? And a lot of that T4 to T3 conversion happens in the gut. 70% of that happens in the gut. So if your gut's not happy, then your thyroid's going to be off. If your thyroid's off, it's going to make your gut off. So those things need to work together synergistically. Um, the next one's gut, right? Because a lot of that's together. If you think about your gut, you can go back to those like in your brain. You have those science books from when you were in school, when you like had those little images of like here's the cell membrane. I had all those little like Lego blocks, and those were like little cells, and then the next little block of little cells, little cells. Well, in your gut, if those little cells are not touching, there's like a gap in between them. We call that leaky gut. It happens when we have a lot of inflammation in the gut. And we don't have inflammation, you're not absorbing nutrients. If you don't absorb nutrients, your thyroid's not going to get what it needs, your brain's not going to get what it needs, your pancreas isn't going to get what it needs. And so there's a lot of things there, right? And then your insulin's going to go up, which is the next box there. And so it's not really just about blood sugar, right? Insulin is a master hormone. It affects a lot of things. And so if your insulin's high, it's going to cause inflammation. It's going to cause weight gain. It's going to have a hard time losing weight. It's going to affect your sex hormone production, things like that, which goes into sex hormones. So then sex hormones, like they obviously rely on your gut as far as the production of them. As far as like, obviously your sex hormones have to deal with your libido and your energy and your sleep and your bone health. And so if those aren't in check, then you're not going to have good energy levels. You're not going to have it all just like circles back and then back to adrenals. So it's like this web of disaster if it's not in check. So shifting gears to PRP briefly. So I don't even know if this will play. It's like a little video. Basically, What is PRP? So PRP stands for platelet-rich plasma. It's a concentration of your own blood. We draw your blood in office, we spin it down in a centrifuge, and it separates. And the little spot at the top is it's like yellow, and that's your PRP. And so what we pull off of that, we call it the golden serum. Is that has everything in it that's great. So it's got your growth factors. It's got so think of growth factors as like what you need to promote blood vessel formation, to reduce inflammation, to stimulate new cells and new collagen and new tissue. You could think about it as like when you get a cut on your arm, like what heals that? That's growth factors. Um, as far as what we use it for, so if I keep going, I think I have, yeah. So what we use it for, so you can inject it right into a joint. People have arthritis, people have tears in their meniscus or their tissue, their tendons, their cartilage. People who have hair thinning, and we can inject it right into the scalp to stimulate follicle promotion, production. I was talking like that first patient this morning in the slides. You can spin it down and inject it right into the clitoris, around the vaginal cuff, into the G spot itself for sexual function. For men, you can do that right into the scrotum itself, and you can help with erectile dysfunction and sensory and orgasm. That's really great for women who have had babies and had a lot of trauma down there, or just trauma in general, or just over time we've just lost that sensory. You can inject it right into the bladder. We do not do that here. You kind of need an ultrasound for that. You can really do it in any tissue, like joints, and um, the opportunities are endless. We can microneedle your face and rub it into your face, and we can help collagen in your face and stimulate better tissue and like fill up scars and all those different things. So it's got a lot. Um, and then we made it, guys. We made it. So here we are. So exclusive offer obviously just for people who attended the webinar. We want to get anybody who's never been to TrueBody before, you get 15% off your first visit with me, where we review your labs and we do your startup and everything. It's usually a $300 service. So you get 15% off of that. And then the first 5 who book can also get a $50 credit towards a PRP service if that's something that interests you. If you're a VIP, which I highly encourage you to be a VIP, you get a free PRP injection, whether that's your hair, your joint, or whatever. So I highly encourage anybody. If you're not a PRP, I will allow you to sign up to capture that if you want to. Our membership program is pretty simple. Basically, you pay in every single month. If your average spend is already a certain amount because you come to the spa, you easily know what would be a good average spend for you for a membership, and that money is yours. You get to spend it on absolutely anything here at TrueBody, and the bonus is you get a discount. So the first tier is 10% off, and it goes all the way up to 20% off depending on the tier you're in. So you can use it on anything. You can use it on medications. You can use it on services, blood draws, consultations with me, facials, Botox, you name it. And so it's kind of a no-brainer for those of you who use the spa for things or are interested but want to save a couple bucks. If you want to get a hold of that, you can call or text the spa 24 hours. We want to leave it kind of a limited window open just because we have other promotions coming up. We have a new service coming to TrueBody that's going to have sorry, I was just reading the chat. As far as I don't even know what I was saying. Girlfriend, so do I have an autoimmune disease if that is attacking my body? You know what, we could call it that, but I know I can fix it, so we can get rid of that for sure. Yeah. So if you have questions, I'm gonna stay on here for a little bit if people want to put more things in the chat, but and if you have things that you want me to do a webinar on, in the future, please let me know. I know I went like 5 minutes over the 30-minute period. If I need to make them longer, I certainly can. I want it to be valuable and not waste your time. So thank you all for attending, and let me know if you have any questions. Lisa, you're amazing. And you're so welcome for all this information. You don't know what you don't know, right? All right. I don't think there's any more questions. So I'm gonna hop off. I love you all. Thank you for tuning in, and I'll see you later. Bye.